Hello, and welcome to the next module for the Institute for Cochlear Implant Training Advanced Audiology course. My name is Terry Zwolan, and I'll be talking to you today about evaluating communication. We're going to look at post-operative evaluation of performance and identification of device failures. I'm going to start with my disclaimer because we're going to be talking a little bit about billing and coding. And so although these things are discussed, the presentation should not be taken as advice. Rather, it's just going to provide you with examples of way various billing codes can be used in your practice. We have two parts to this lecture. The very first part, we're going to review the various procedures used to evaluate post-operative performance with a cochlear implant. So everything we need to talk about post-op testing. And then we're going to review pre- and post-operative procedures that contribute to determining if a cochlear implant has malfunctioned. So let's begin with post-operative follow-up. We know that it's essential because it helps us monitor the quality of our mapping. It helps us determine if additional intervention is needed. We might recommend a child have additional speech-language therapy, or that an adult enroll in oral rehabilitation because they're not really meeting our expectations. And importantly, these appointments help us monitor both the internal and external components of the cochlear implant system. And it's really the responsibility of the audiologist, the surgeon, as well as the speech pathologist to monitor performance so that we can all ensure that the outcomes with the device are optimal and optimized for that patient. So a typical post-operative follow-up schedule will vary depending on your clinic. I've put up the typical schedule at U of M. A few years ago, we went to scheduling the activation 2 weeks post-implant rather than 4 weeks because the devices have gotten a little bit smaller. The surgery is less invasive, and we really feel like they're on par for activation at about 2 weeks. And then we also changed it. We used to do 2 days in a row for the activation. We eliminated that down to one appointment that lasts about 2 hours. And we have found that patients are really happy with that as well as the clinicians. So we do the activation 2 weeks following surgery. And then for adults, they're seen 1 week, 1 month, 3, 6, and 12 months later. After that, we ask them to return annually. For some patients, they really don't need to come in annually. They can come in every other year to have everything checked. Children, we're a little bit stricter on having those more frequent appointments. So they're also seen at their activation, which is about 2 weeks after surgery. Then they're seen 1 week, 1, 2, 4, 6, 9, 12 months later, and then biannually or annually thereafter. Formal speech recognition for both children and adults is typically performed at 6 and 12 months. However, we're going to talk a little bit about informal testing, and if your informal testing indicates they're not doing as well as you think they should, then you might want to move up your formal speech recognition testing to 3 or 4 months. You would hate to wait 6 months to identify that there's some type of problem. And sound field testing can be performed at any appointment, and really it's the only way that we have to verify detection skills and that we're providing them with adequate access to sound information. And anytime you do a formal evaluation of auditory rehabilitation, when you put them in the sound booth, you should always be testing their sound field detection skills. I won't go into all of these. This just gives you an idea of the average length of appointments at the University of Michigan. You'll see that they vary depending upon if there's formal testing in the booth or if there's just programming. Billing and coding for the programming. So it's important to remember we talked about 92626 in the previous lecture, but now we're going to be talking about programming codes, and they're not time-based. 92626 is time-based, but programming codes are not time-based. This means that for some insurers, such as Medicare, you will receive a flat fee, no matter how much time you spend with a patient. So I could see a patient for 30 minutes, or I could see that patient for an hour and a half, just do programming, and I'm only going to get paid the same amount, no matter how long I spent with them. So it's really important for you to consider and evaluate how much time you're spending with your patients. So this slide gives you an idea of the Medicare fee schedule for 2021. We have the programming codes along this side. We have 92601, 2, 3, and 4, and they're divided for less than 7 years of age and 7 years of age or older. and this is the reimbursement that you'll receive. So if you're spending 2 hours on a typical programming for someone over the age of 7, you'll find quickly that your reimbursement is pretty low, and you're probably losing quite a bit of money on that appointment. So it's just important for you to have access to reimbursement information when you're helping to determine the length of the appointment that's needed for your patients. At U of M, an additional amount is charged if the appointment includes a test assist. So we use test assistance anytime a child is 4 years of age or younger, and we'll use that for programming as well as for evaluation in the sound booth. With insurers that pay a flat fee, the additional charge will be ignored. So like Medicare, if we use a test assist and we're billing Medicare, they're going to pay just their regular fee, and we won't get any additional reimbursement. However, some private insurers will pay a percentage of the charge. So if that happens, and we increase the charge because of the use of a test assistant, then when they pay a percentage, they'll be paying a percentage of a higher charge. So our reimbursement will hopefully recoup some of that extra cost that goes into putting 2 providers into an appointment. Sound field testing we talked about can be performed at any appointment, but remember, if you only do sound field detection, so if you just do programming and then you put them in the booth really quickly to verify their detection, you may choose not to bill, especially for a Medicare patient, because CPT code 92552 is typically not allowed with programming per the NCCI edits, and we'll talk a little bit more about that. So what are the edits? Well, the CCI edits provide specific information regarding codes that are or are not allowable on the same day with the same patient when performed by the same provider. So they're an automated edit system to control those pairs that can be reported by you when you see a patient and you perform more than 2 procedures. Many third-party payers adopt the CCI edits, so it's important for you to work with your billing department to determine if you're going to use those CCI edits for other third-party payers other than Medicare. So on the discussion board, I've posted information that was obtained from ASHA's website, and basically it's just a summary that you can print out and have handy rather than having to go to the website for ASHA. And what you'll see here is that here's the CPT code, and this is just related to programming codes. And so you've got 8 of them here, but it's really the 4 programming codes, and there's a yes row and a no row, a yes, no, and a no row. So this tells us that the programming, the activation less than 7. If you use these codes, you can receive payment for both codes if you use the 59 modifier. But here's an example of 92552, which would be the air conduction only for the sound field thresholds, and that is disallowed. So that means that even with the 59 modifier, you'd only get paid for one of those, and it would probably be the cheaper one, which would be the 92552. So it's important to understand the CCI edits and how they're going to impact your billing, and importantly, how they're going to impact your reimbursement. So let's move on to a brief discussion about medical follow-up. And that will vary from clinic to clinic depending upon the surgeon preference, how close the surgeon and the audiologist are physically located, even the distance of the patient. At the University of Michigan, the patient will see the surgeon for a post-op visit, suture check about 10 days after surgery, so just a couple of days before their activation. And then they'll see them again 6 months post-implant. We like that they see them at 10 days because if they're not ready for that 14-day activation, then we'll go ahead and move the activation back if the surgeon feels as though their suture hasn't really healed well enough. And then our surgeons will see them back 6 months post-implant. Sometimes the physicians like to hold those appointments virtually, and sometimes they're almost always coordinated so that the audiologist sees them first at 6 months, followed by the surgeon, so that we can provide the surgeon with copies of their test results, so then they can see if that patient is meeting their preoperative expectations for performance. After that, our patients don't routinely go back to see the surgeon. They see them as needed. So it's really important for us to refer promptly if any medical problems are noted after that 6-month check, particularly. So if they have balance issues, if there's all of a sudden they have issues regarding their incision, or if there's swelling around the incision. So the communication of these interim medical issues is essential, especially if the physician is trusting us to triage any needed medical treatment for the patient. Postoperative audiometric testing has become more essential since we're seeing more patients with postoperative residual hearing. Years ago, people would be really deaf in both the implanted ear and the non-implanted ear, and a lot of them didn't wear a hearing aid in the contralateral ear. But now we're encountering patients who use their residual hearing in the implanted ear, as well as they're more likely to have some usable hearing in the contralateral ear, resulting in greater numbers of bimodal users. So we need to test and perform probe microphone measurements for both the implanted ear if they're using an acoustic component, and for the non-implanted ear if amplification is used. And we're seeing trends that cochlear implant audiologists are much more likely to manage the hearing aid in the contralateral ear than they've done in the past. So it's really important for you to make that part of your protocol as to when you're going to perform real ear measurements on either the implanted or the contralateral ear. If you are not the dispenser for the contralateral hearing aid, you should talk with your patients and remind them that they should see their hearing aid audiologist or hearing aid dispenser at least once a year, and explain to them what real ear verification is, and encourage them to ask their audiologist to do that if they're not already performing that regularly. Audiometric testing is typically performed at the beginning of the appointment because it might impact your mapping. If there's an acoustic component, you should always include both air and bone conduction because it helps us identify if there's a conductive component present. Tympanometry should be performed to further evaluate the middle ear, but check with the surgeon, especially if you have a quick activation date soon after surgery. They might not want you to do tympanometry right away. They might want to have you wait a little bit to perform it a little further away from the surgery date. And if a conductive component is present, it's really our role to monitor the hearing loss and work with the physician to help treat that conductive component. Testing performed at device activation can be used as a baseline to monitor potential change in thresholds over time. Those changes that occur over time should be reported back to the surgeon. That way they can help understand or know more if the surgical procedure that they're using for hearing preservation is working. And maybe they'll consider altering a little bit if it turns out that it's not as effective as they thought it might be. And it's good to monitor it over time because we know that sometimes people will lose their hearing over time. And that might be a result of the surgery, or it might just be because they would have had a progression in their hearing loss anyways. So if the patient, especially if the patient uses an acoustic component, then audiometric testing should be performed regularly. If you have an acoustic component that the patient is using, a timeline to consider would be to test their audiometrics at 1, 3, 6, and 12 months post-activation, and then annually thereafter or whenever the patient is seen for programming of their device. This adds extra time to the appointment, and audiometric testing is typically disallowed, as we showed, on the same day as programming codes per the edits. So some centers choose to balance bill the patient for this code, while others will roll this time into the auditory rehab eval if there's one that's being performed during that appointment, or they might simply choose not to bill for that procedure. And again, that's part of your center's protocols to determine what you'd like to do. Similarly, with post-activation verification, you can determine if the acoustic component is meeting the prescribed targets. So in this example here, we have a programming computer plugged in where we can make adjustments to the settings on the processor and onto the acoustic component, and then we can watch in situ while the verification is going on to see if we're able to meet those low frequency targets that we've set for that acoustic component. In terms of billing for that time, some clinics will use CPT 92594, which is electroacoustic analysis for a hearing aid. But if you're programming when you're doing that, the CCI edits disallow the use of those with the programming codes. So similar to the audiometric testing we just talked about, some clinics will require patients to pay for this out of pocket. Others might use 92700, which is an unlisted otorhinological service or procedure, and others will just simply not charge and consider it part of the programming appointment. There are several regular checks that are really essential for each appointment. Checking of the incision and the magnet area. So we actually have people pull their hair back and look at their incision, and then we take off the coil and we look for any redness or necrosis of the skin underneath the magnet. That would be a strong sign that that magnet is too tight and we need to, or too strong, and we need to decrease the magnet strength. It's important to do a regular listening check of the microphone, especially for the adults. It might be the only time someone has listened to their microphone. It's a good time to talk about them changing the filters on their microphones or on their T-mic. We can do an informal assessment of their detection skills. The Ling-6 sound test is good to use with both adults and children. Informal speech recognition if you're not going to put them in the booth. It's good to check your data logging and discuss that with your patients or with the parents. It's important to talk about their eligibility for a sound processor upgrade if they've had their device for a few years. And we recommend that you document that you've done all of these in your report. And we'll talk about that in a minute. So sound processor upgrades, it's really important to have a strong and consistent policy regarding when you will supply your patients with a letter stating that that upgrade is medically necessary, because a lot of insurers require a letter signed by the surgeon indicating that the upgrade is medically necessary. Some insurers, even when you provide them with that letter, still won't upgrade. It depends on their specific policy. So some of the things that you might want to consider as your group, what we did at the University of Michigan is as soon as Medicare came out with a policy that they will cover upgrades if the device has been used for more than 5 years, regardless of condition of the processor, we will provide a letter of medical necessity if there's a new processor available and if the patient has used the device for at least 5 years. And this way we remain consistent across all of our patients, and that's just the policy that we've chosen to adhere to. So for pediatrics, you have the same essential components at the beginning of the appointment. It's just as important to check their microphone, their incision, their data logging. Children will have a increased likelihood of ear infections, so there's an increased need for otoscopy, TIMPs, and coordination of care with the surgeon if you notice any problems going on. The Ling-6 sound detection is great with children, and the more the parents see you do this, they'll go, oh, right, I'm supposed to be doing this every day with my child. And it's a good task to talk to them about, to demonstrate to them as the child matures and you use it in different ways. So for both children and adults, you should document that you have done these in your chart note. Just an aside, the Ling-6 Sounds, Hearing First, has great resources for parents and professionals regarding the Ling-6 sound test. If you're not a member of Hearing First, I would recommend that you consider joining. It's free, so you and the families you work with will have access to the amazing resources that Hearing First provides. And here's an example of the daily listening check for babies, for toddlers, and for young children that you could give to your families and would be great to use as a handout. So we talked about documenting those things you're doing at the beginning of the appointment. This is an example of the template used at the University of Michigan. Each and every appointment will document for the right implant, the left implant, what type of processor it is. If we listen to the microphone and if it sounded good, sometimes it might say poor, provided with loaner, or poor, changed microphone covers and improved. But we can give a little summary there. The implant site, this shows that we checked it. And sometimes as we're going through the appointment, we'll go, oh my gosh, I see my template, I forgot to check the implant site. And it reminds you before they leave to go take a look at their implant site. It's good to note their magnet strength because sometimes they're going to call in and need a weaker or a stronger magnet, or the implant manufacturer might contact you to verify the magnet strength. So we found it really helpful to include that in our template. We also provide a brief comment about their impedances because that reminds us to look at them and also to look for changes over time. We like to document the processor serial number and if they have a backup processor. Data logging, we sometimes import a picture of the data logging, but we always indicate the amount of hours that they're wearing it each day on average for each year. So we recommend that preoperatively that you inform the parents of your ability to do this so that they don't feel as though you're spying on their child, and discuss the expectations for device use. One term we use is eyes open, ears on, and we let parents know before surgery that that's going to be our expectation and that we're going to be working with them to facilitate full-time device use, and data logging is part of that. One great thing that we do as well is our SLPs will monitor data logging prior to each therapy appointment. They're great with counseling families if the data logging shows reduced device use. It is a little bit of extra work. You have to make certain that the speech language pathologists have access to the programming software so that they can monitor the data logging. They need to document it in their chart because sometimes the data logging, it restarts the clock once they've read it. So it's important to coordinate with them for the data logging, but sometimes the speech pathologist will notice red flags. It might be on their head, but not connected, and they can alert the audiologist to this, and we're much better together as a team. I want to show you some data that we have for our adults and peds. So along this axis, we have the total number of hours. It can range from 0 at the bottom all the way till 20. And then we broke them down into different age groups, 18 to 30, 30 to 40, 40 to 50, 50 to 60. And you'll see the median for these various age groups. And what you'll see is that our youngest adults, those who are between 18 and 30 years, during their first year of device use, they use their device over 2 hours more per day when we compare it to the average of 11 hours by our patients who are over the age of 80. It's important to remember, though, that 80-year-olds sometimes take a lot of naps. They might sleep more. They might sleep longer at night than our younger, more active patients. But it's always good to just communicate with your patients. I think these numbers are really great. I think it's important for all these groups to be wearing them on average about 12 hours per day. We looked at younger children, and we find that the younger babies use their device less often during the first year. So we've broken them down into time frames during the first year of device use. So here's week 1, week 2, and so on. And then we've got the different colored bars to represent the different age groups. And what we see are our youngest ones, those who are between 1 and 2 years of age. Well, they tend to sleep more than those other age groups. So like our elderly patients, our babies sleep a lot more. But as they age, they have more awake time and they have more device use time. But the important thing is to communicate with parents about eyes open, ears on. This was a real eye-opener for us. We now work even more closely with our families to make certain that they increase the device use, because 6 hours at 6 months is not a good number. We want it to be more than that. Postoperative testing, let's move on to that. So we know it's important. We want to monitor the function of and the patient performance with this surgically implanted device. Is the patient meeting the expectations? Are they doing as well as we thought they would do with an implant? Is our mapping effective? And is the device providing them with adequate access to sound? And remember, we know that from their sound field thresholds. So the frequency of testing will vary depending upon your center's protocol, along with other factors such as how far does the patient live from the clinic. Again, it should be performed by the 6-month post-implant interval. That way you can catch any problems. And again, with your informal screening, if you see problems, then I would recommend putting them in the booth for formal postoperative testing sooner than that. One question that has often come up in this class is, should speech recognition testing be performed before or after mapping? Some clinics will perform it before testing, prior to mapping, and then if everything looks good, they may not make changes to the patient's program. At the University of Michigan, we would perform testing after mapping, more so to verify the mapping that we just did. If the patient specifically requests their map not be changed, which does happen, then we'll still put them in the booth and we'll say, okay, if everything looks good, if it's just as good as last year or better, we'll leave it. But if for some reason your detection is not good, or if your outcomes are not as good as they were last year, then we're going to need to probably tweak your map a little bit. It's always good, even if you don't do mapping, to perform impedance telemetry and to check the data logging, even if those mapping changes are not made. So implant sound field thresholds, we're going to talk a little bit about calibration because most audiometers are not calibrated for narrowband noise presentation via the speaker. Although narrowband noises are typically calibrated for masking using inserts or headphones. So check with the person who does your calibration if you like using narrowband noises to make certain that they're calibrated appropriately. But I would say in most clinics, warble tones are usually used to evaluate sound field detection. Narrowband noise thresholds, if you use them, they're typically about 10 dB better than the warble tone thresholds, just because they have the narrow band, so they have greater frequencies included in the sound than the warble tone thresholds. CI patients typically demonstrate sound field thresholds that fall between 20 and 25 for children and 20 to 30 dB HL for adults. And that provides us with the assurance that they're getting adequate detection, good access to speech information, and that they're able to hear low-level speech. So remember, your sound field thresholds can be influenced by the microphone sensitivity and should be obtained at the patient's normal use setting. So sound field thresholds are not as accurate as real ear verification when used for an acoustic component. So if your patient uses an acoustic component, you should probably perform real ear verification instead of the sound field thresholds for those low frequencies. Again, calibration is essential for all of your recorded materials. Recorded materials should be used whenever possible, and frequent calibration is essential. Calibration should be performed prior to each test session, particularly if a variety of clinicians are using the booth, if they're in and out, and if they're switching out the CDs, if you've got different CDs for adults and kids, then your peak level meter is going to be off a little bit, and you'll need to calibrate it before each appointment. It just takes a minute. Most booths are calibrated so the patient sits about 1 meter from the speaker, which puts them away from the walls in order to reduce reverberation. And the loudspeaker is typically situated at the level of a typical seated person's head, so about 39 inches from the floor. And that's where you're going to want to hold the sound level meter if you do some calibration. Test materials will typically include that 1 kilohertz tone to help calibrate the input signal from either the CD or the computer file. And the sound level meter with A weighting should be used to measure the output of the, as the audiometer dial is changed with your speech recognition materials. And it's really great to have that sound level meter handy and to do that often because sometimes the settings can change. It's important to remember to calibrate for testing in noise, just as important as it is for quiet. And when you do the calibration, you need to do both channel A and channel B because typically the signal might come out of A and the noise might come out of B. The MSTB recommends presentation at 0 degree azimuth. So again, make sure that you check to make sure your speakers are calibrated for a 0 degree azimuth and not calibrated for a 45 or 90 degree presentation of the stimuli. So check with the person who does your calibration. And I would recommend you reference chapters 2 and 6 in Renee Gifford's book because she provides really excellent information regarding calibration. The MSTB will show you, again, gives you this nice demonstration that they want both the signal and the noise to be at 0 degree azimuth, so that would be an SONO setup. We find that some clinics are using a different setup because they've participated in clinical trials, and it really depends on the purpose of the testing as to where you're going to deliver the signal and the noise. So just make certain you understand why you're presenting it as you are. Document in your chart what that presentation was. And it's good to follow the MSTB recommendations for your standard clinical care. Presentation level, why 60 dB? Well, we talked in the last, in module 1, why we went to a softer presentation level of 60. But I put this up here because in this article by Jill First and colleagues, their data supported the use of speech recognition tests presented at 60 or 50 dB SPL. So if you find that some of your test materials are being presented at 50 dB for a reason, then it's good to write that into your report. And actually, if you do that preoperatively, then it might be helpful for you to cite this paper in your letter as to why you used a presentation level of 50 dB. So presenting test signals in noise, we determined earlier, yes, it's appropriate. almost all of you are using testing and noise, or I believe all of you are, based on our polling that we've done. If you administer tests in noise preoperatively, then you should probably utilize the same signal to noise ratio postoperatively, so you have an idea of the efficacy of your recommendation. If you find that your patients are worse off with at that signal to noise ratio, that's really important to know. And you'll find that the more difficult the test situation, clearly the lower your scores are going to be. So people are more likely post-implant to maybe use a couple of signal to noise ratios to evaluate performance, because that gives them a better idea, and they've got more leeway with that because of the better hearing afforded post-implant compared to pre-implant. So some of the things to consider when defining your clinic's test protocol for adults, again, the length of the appointment, the billing, the coding, the reimbursement should go into that, the amount of things that you're going to do in the appointment, but on your annual evals, you're going to want to think about your protocol content. I would recommend that you always include sound field detection to verify your mapping and to check for audibility. Clinics will also include words, sentences, and sentences and noise. And most centers typically follow the abbreviated protocol of the MSTB, which includes CNC words, AZ Bio Quiet, and AZ Bio in noise. If you've used a cognitive screener preoperatively, you might want to repeat that annually. Patients are used to having you do it, and it's a good way to sort of watch and keep track with those cognitive screeners. And then you might want to administer some other questionnaires, such as tinnitus or quality of life. I've just provided this as an example in helping you develop your protocols. There's some nice time estimates for the various procedures that you would include in your protocol, and this might be helpful. I've also, on the board, I've posted the University of Michigan Adult Post-Op Battery. This is our protocol for post-op testing. We've included information about unaided testing, and then you'll see there's 3 primary areas, those for a unilateral implant, bilateral implant users, and bimodal implant users. One thing to point out here for the bimodal users is you'll want to consider a hearing aid evaluation for the contralateral ear, or have time for a bilateral cochlear implant evaluation. Don't forget about that other ear, either in the unilaterals or in the bimodals, because part of what we do is track that other ear to know when it's right to provide a bilateral cochlear implant. So you're going to want to define your clinic's test protocol. Here's some considerations for children. Again, the length of the appointment. Typically, those are a little bit shorter than adults, and they're oftentimes seen more frequently because we're not able to get as much done in the appointment. You might need to split it into more than one appointment. Again, sound field detection is essential. Those children are not going to tell us when they're not hearing as well. And then audiometric testing might be needed of the implanted or the non-implanted ear, really depending upon their hearing status. And the materials that you use will vary depending upon the age and linguistic abilities of the child. Most clinics will consider administering materials at both higher and lower presentation levels because, again, remember, when we talked about the teacher's voice in a classroom can sometimes be as soft as 50 dB or softer. So it gives you a good feel for how they can do with low-level speech. You might want to have a preferred order of presentation. So when you see our protocol, you'll see that all the clinicians, we try to follow that order specifically. So that helps ensure that some measures are collected consistently on most or all of the children. If somebody starts with a different test, then you're going to have sort of half as much of one test as you will of the other. And it's just, it's better to have a lot of data that you can look at. And you should, from time to time, evaluate and update your protocols to ensure consistent utilization, that you feel as though the tests that you've included are valuable. And what you'll find is as the child ages, they'll be able to do more and more tests. So eventually they'll get to the adult protocol, and you'll want to determine about what age you recommend that children be transitioned over to an adult protocol. So for bilateral implant users, it's important to evaluate each ear separately, as well as in the bilateral condition for detection skills, as well as for speech recognition. Don't just put them in the booth with both their implants on and evaluate how they're doing, because you might be missing some signs of device malfunction in one of the ears if you do that. And for bimodal users, don't forget about that other ear, and your testing can help determine when the time is right to recommend a bilateral CI. So here is our University of Michigan Pediatric post-op battery protocol. Again, we've got it broken down into unilateral implant user, bilateral, and bimodal. And again, you're going to want to consider an evaluation for a bilateral CI. At the end of the appointment, you're going to want to communicate with the referring audiologist. It's really important afterwards to communicate with the patient's referring audiologist regarding their outcomes. I think one of the reasons we don't get as many referrals as we should is because the referral sources are really not familiar with the amazing outcomes that our patients are receiving. So if we send a report to them and say, thank you, the patient you referred a year ago, their scores have gone up from 10% pre-op to 80% post-op, they're going to be like, wow, I didn't realize they did that well. And then they're going to start seeing other patients and they're going to start thinking more about referral. So I really think that communicating with the referral source will facilitate awareness of the implant outcomes, as well as facilitate continued referrals from that referral source. Also, you can consider co-managing patients or referring patients back for management of a hearing aid in the contralateral ear or for assistive devices as a way to build continued referrals and continued communication with that referral source. So we're going to look quickly at billing and coding. Most speech recognition testing performed with the implant recipients is billed as 92626. Again, remember it's a time-based code, so you're going to want to spend at least 31 minutes or half of the allotted time for that procedure, 1 minute over the half mark, so 31 minutes. You can add on 92627 if you exceed an hour, and this code 92626 and 92627 can be billed along with the programming codes of 92601 through 4. We went through that, but for Medicare, you need to use that 59 modifier. So for 92626, when I click on that in my electronic medical record, this will pop up for me. I'll want to include the 59 modifier in here, and when I do, it will pop up as a distinct procedural service because that's what that 59 modifier is indicating. It's indicating that I'm using 92626, but it's separate and distinct from the programming. And then I also need to indicate my start and end time for that 92626. And this is different from the template we talked about previously, where we have a start and end time in our templates for the start and end time of the appointment. And this is specifically related to 92626. Again, we've got the NCCI edits handouts on the board posted for you. And remember that there's columns for the 59 modifier when you can and cannot use those with Medicare patients, and you need to check with third-party payers to see if that holds true for them. So at the end of the appointment, it's important to communicate the test results of your testing to the patient, to the parents, or even to educators or referral sources. You're going to want to compare your results to their preoperative scores to see if they're making improvement and review those with the patient so you can show them how well they're doing. If you compare your results to their previous post-op scores, you'll make sure that their performance is good and stable. Hopefully it's improved over time, and you would just want to make sure that it hasn't gotten worse over time because that could indicate something that's just not right. So you'll want to do that, and if you do this with patients, they'll then understand why they come back annually. They'll be more likely to return annually, and they'll feel more fulfilled and engaged about that appointment. So I'm going to end there. Thank you for your attention. Let's take a quick break, and then we'll start on part 2 where we're going to look at device failures.